Hello, everyone. My name is Eileen Regan. I'm the CCO at Examen, and it is my pleasure to welcome you all to the 9th and the final webinar in our 2021 Male Fertility series. So as many of you know, these webinars have taken place on a monthly basis, and we've been joined by many experts in their field of fertility treatment or therapies. The webinar has been open to all. We have a wide range of participants joining us, from academics, healthcare professionals, urologists, as well as the men, couples and individuals on their own fertility journey. Just to say that the views presented in the webinars are the views of our speakers, not necessarily of our company Examen. So you're all very, very welcome to join us today. And just let me introduce you to our two speakers. So we are joined by Professor Andrea Salonia, Professor of Urology and the Dean of the Studies of International MD Programme at the University Vita-Salute San Raffaele. Professor Salonia is Staff Urologist at the Academic Unit of Urology of the IRCCS Ospedale San Raffaele in Milano, Italy, as well as the current Director of the URI Urological Research Institute, the Translational Research Institute of the IRCCS. Professor Salonia's major research interests have a specific focus on pathophysiology, diagnosis and management of male sexual and reproductive health with a targeted translational approach. Professor Salonia is the current chairman of the Male Sexual and Reproductive Health EAU Guidelines panel as well. And also to introduce you to our chair, Professor Sheena Lewis, who is the founder and CEO of Examen and an honorary professor at Queen's University in Belfast, where for the past 25 years she has dedicated her research into novel tests for male infertility. She is currently an executive member of the Association of Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She has published over 100 full papers as well as numerous book chapters and reviews. And she has been past chair of the British Andrology Society, UK National Representative and chair of the Andrology Special Interest Group of the European Society of Human Reproduction and Embryology, executive member of the British Fertility Society, and was a founder member and vice chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examen, where it markets an exact range of male fertility tests powered by the Sperm Comet technology, which is now the market leader for sperm DNA damage testing in the UK and Ireland. So just before I hand over to Professor Lewis, I just want to run through some housekeeping. So we'll have a 5-10 minute introduction by Professor Lewis regarding the company on our webinar series and today's topic. And then Professor Salonia, our special speaker this month, will talk for approximately 30 minutes. And at the end, we'll allow then time for question and answers with both our speaker and our chair. So please do post your questions through the talks, through the Q&A panel, not the chat function. If you have any technical issues, please use the chat function and we'll do our very best to help you. But please use the Q&A panel, and then you'll have the opportunity also to rate questions. So we'll make sure the most important ones get asked. Attendees are muted throughout, so the videos are enabled for our speakers only. And just to let you know, all the events are recorded and will be made available on the events page of the Examen website shortly after. So give us 24 hours, hopefully, to get those online for you. And finally, 1 CPD point will be awarded for attendees for the 1 hour event and a certificate circulated afterwards as well. So at the end of the session, you'll be invited to rate the event. Please do so, and we welcome your feedback and suggestions for future events in the series, and next year's series, I should say. So without further ado, let me hand over now to our chair, Professor Sheena Lewis, to start the session.
Good evening, everyone, and thank you very much for spending some time with us this evening. I know it's probably the end of a long day for all of you. Our speaker this evening was telling us that he'd been up from 4 a.m. and what he wanted to do over Christmas was sleep. And I fully understand how you can feel. So we very much appreciate your company with us. So tonight we're going to talk about infection, a common cause of male infertility. And I think you're going to be very interested in what's going to be said tonight, because this is something which we ignore very often, and yet it's something which I think many more people experience and suffer from than you might have thought before you came along to the webinar this evening. Just to tell you about our company, Examen, and our mission and vision. We are a university, a scale-up company, and because of being associated with the university, of course, one of the most important things for us is to educate people and to raise the awareness of male infertility by giving people knowledge and giving them the opportunities for advanced testing. And of course, we want to demonstrate that the tests that we've been working on in our research program over many years can improve fertility outcomes. If we optimize sperm health, irrespective of whether the person can have his children naturally or with assisted conception, improving the DNA quality of a sperm is going to make things better all around. For many years, there's been inadequate testing for men, and we believe that that has led to poor treatment decisions. Of course, you need a semen analysis. Of course, it's the gold standard, but that only tells you what the outside of sperm are like. How many do you have? Can they swim? Do they look good? But it's really much more important to find out what the paternal genome is like, because it's the quality of the man's DNA that's really going to make his children look and act like him and will lead to healthy live births. A little bit about our company. We've been around for over 10 years now. We started in 2010, and we were then called Lewis Fertility Testing. Our first customers came from the Republic of Ireland, and then with time we got a CE mark, we got VC investments, we became a bigger company, we got ISOs, and we became international and had signings from other countries in Europe. Over the last few years, we've expanded considerably, both in our premises and also in our staff. We've rebranded to call ourselves Examen, and we are very ambitious in the plans that we have for the next couple of years. And I think you'll both see and hear a lot more of us. The tests are based on 25 to 30 years of research, started by myself, and with a very, very clever team. We've been able to put a few papers together. And these, of course, have all been non-commercial peer-reviewed studies because it all came from pure academia. Why would someone want to use us rather than one of the other companies that offer DNA testing? Well, because we can measure male infertility more accurately, we believe, by looking at the DNA rather than looking at a semen analysis. We believe we offer an excellent customer service, and that appears to be the case from to many of our clients. The Comet assay is the only test on the market that actually reports the DNA damage per sperm. We can detect single and double strand breaks. And now the proof of the pudding is the fact that we're being used by many of the clinics in the private sector in the UK. We work to the highest standards, and we're certified now for an ISO 13485. What we believe our testing can do is allow men to take back control of their fertility and become equal players, because we know for a long time men have been neglected and emasculated, and they have been disinclined to continue on the fertility journey when failure came early in their journey. But if they are taken on board, given a chance to improve their sperm quality, they remain much more engaged in their treatment. To our great delight, over the last couple of years, the international guidelines have brought sperm DNA testing into the guidelines. And as you can see, our speaker tonight was the chair of the European Association of Urology. And although a semen analysis was, of course, the first thing that must be done, it also became clear in those guidelines that there are some people for whom more complex testing is needed, particularly those who have unexplained infertility by a semen analysis or recurrent pregnancy loss. Also in the ESHRE guidelines for recurrent pregnancy loss, which were first written in 2017 and will be updated next year. I've been a co-author of this, and for the first time, we've been talking about men and miscarriage, and that, to our minds, is a huge step forward in diagnosis. And then the American Urology Association and the American Society for Reproductive Medicine got together to write joint guidelines saying that the male partner should be evaluated by a male reproductive expert. Now, that was music to our ears, because for 40 years, men have not been examined. Everything has been focused on the woman. And now, if there are failures in ART or recurrent pregnancy losses, the male partner should be examined, and consideration ought to be given to evaluation of the DNA. And then finally, the WHO manual, which came out earlier this year, has said that an extended examination in certain circumstances ought to include DNA fragmentation. And that is a huge step forward from the 2010 edition, which said that DNA fragmentation was simply for research. Now, our speaker this evening is very much in agreement with us in this case. Last year, a large paper was published showing that normal sperm parameters per se do not reliably account for infertility. Professor Salonia is chair of a very large research group, and the studies which come out of his lab are enormous. And this particular one was nearly 2,000 men. And in this study, he found that only 12% of the men who were coming with infertility investigations had normal semen parameters, and only 40% of the men who were supposedly fertile. So this is an indication that we need more than just a basic semen analysis. I could spend the whole of the next hour telling you about Professor Andrea Salonia. He is a urologist, as we heard, in the prestigious San Raffaele Hospital. He has numerous areas of clinical expertise, including the treatment of bladder and penile cancers. He's never been content to just treat patients by traditional methods, and he's always been successful in developing a multidisciplinary approach. One of the most recent things he's done is to look at the urological and andrological disorders of patients with neurological diseases, a group of patients who've never been cared for in this particular way, people with Parkinson's and people with multiple sclerosis. And this has resulted in the MS Centre of his academic hospital being recognised as one of the leading centres in research in this area in Europe. And to our delight, over the past 15 years, Professor Salonia has expanded his interests to include male reproductive medicine, both from the causes of male infertility to novel treatments. He's published over 250 papers, and again, in this area of reproductive medicine, he has developed a collaborative team with gynecologists to publish some of the pivotal papers that we have on the socio-demographics, lifestyle aspects, and the comorbidity of infertile men. Now, these are a number of the papers. You can see these online later if you want to go back to them. Some of the most important papers that we have around at the moment. Tonight, Professor Salonia is going to talk to us about semen infections, something, as I said, we don't think about very much, but after you have heard what he has to say tonight, you're going to be thinking about it a whole lot more. So it's my pleasure to give the floor now to Professor Salonia, and we look forward to hearing what you have to say to us. Thank you very much.
Here we are. Thank you very much for this prestigious invitation and for your kind words. Greatly appreciated. I want to start sharing my slide tonight. Wonderful. Okay. Thank you very much. Good evening, everyone. The topic tonight is not that easy, since infection per se are, would say, quite neglected in the field of male reproduction. And even more important, I will deal with my between brackets, EU guidelines, where infections are roughly neglected, which is a terrible thing to say, but at the same time, this is reality. Let me try to move. No conflict of interest at all. As I told you before, I'm going to deal with the EU guidelines on sexual and reproductive health. I'm more than happy to say that they are probably the most comprehensive guidelines dealing with sexuality, sexual health, reproductive health, and reproduction as an issue for both quality and quantity of life in men. And this is the case for me to say that our guidelines open with this important recommendation. Both partners must be simultaneously categorized in terms of causes of infertility, which means at the end of the day that we should consider both partners at the very same time. This is not unfortunately the case in the real life setting, and many data are still telling us that, fortunately or unfortunately, in the ART centers, patients are considered the female part of the coin and less frequently men. This is important for us since many data are coming out, and the scientific value of those data are certainly much more precise and increasing, even in the field of potential causes of infertility, thus including infections. One of the issues is to try and dichotomize what kind of infertility we are facing to. And interestingly, we are dealing mostly with primary infertile men, which means the more severe type of patients as compared with secondary ones. In this setting, I want to describe what is the pathway we are used to follow. And this is also the one which has been proposed by the EAU guidelines. We start with clinical history, and clinical history means taking a good medical history, taking a good reproductive history, taking a good sexual history as well, thus including the possibility of having any type of sexually transmitted diseases. Once again, neglected issues in the field of reproduction many times. Therefore, we have to perform a physical examination on every single patient coming to the office and seeking medical help because of reproduction and reproductive issues, thus including potential findings concerning, for instance, condylomata and HPV warts at the level of the penile shaft, the scrotum, and as well as the groins. Semen analysis, third issue, that should be always considered. At the same time, we should try to understand whether semen culture could be as much important as the analysis, the macro one, of semen parameters. Hormonal levels, I want to start trying to deal with SARS-CoV-2 infection, for instance, and the correlation between reproduction and hormonal levels, and so and so. If you got a look to this very busy cartoon, it is a sort of sum up of those causes which have been associated with male infertility and risk factors for male infertility. Get a look to the list of potential causes. Unfortunately, there is no infection. And the skepticism concerning the real role of infections at the semen level in men coming to the office because of infertility is quite neglected, is very, under-evaluated. If you get a look to the fact that roughly 30% of the cases, overall 40% of the cases with infertility belong to the group of idiopathic infertility men, this could mean that someone may have an infection, which is an asymptomatic one, and that could be the reason for him to become infertile. This is to study, and data seems to suggest this could be the case. If you get a look to the chapter once again, and this is the case even for the American Society for Reproductive, small paragraphs concerning the issue of medical and reproductive history to understand whether a patient has ever had something like genital urinary infection, thus including sexually transmitted infections. Indeed, if you get a look to the very famous acronym MAGI, which means male accessory gland infection / inflammation, that could be the case in many situations in men presenting for infertility. They may have suffered from urethritis, prostatitis, which is probably the most compelling and relevant and tough situation to be treated, orchitis. Orchitis, for instance, is very clearly observed in the era of pandemia, which means COVID-19, and data are increasing in this setting, although we are quite skeptical concerning the quality of the data themselves. And finally, epididymitis. Why these situations are so important? If you get a look to those men coming to the office because of obstructive azoospermia, one of the cases and one of the causes is actually associated with epididymitis, since the obstruction per se could arise at the level of the epididymus, and therefore obstruction is there. If you do not evaluate whether that gentleman has ever had something like an infection at the semen level, this could be the case for you to miss understanding a real risk factor for infertility. Among the magi, you may have this kind of data, the prevalence, which range between 5 to 30% of the cases. Once again, epidemiology is not that rich in this setting, although it is really rich of cross-sectional and retrospective studies. And therefore, we do have data telling us there is probably a huge correlation, even from the causes standpoint. There is probably common ground fostering infertility and infections in terms of bimutual correlations. But data are retrospective, cross-sectional, and therefore we really urgently need something prospectively speaking just to corroborate these kind of findings. Patients may come in because of symptoms, urinary disorders, mostly LUTs, for instance, chronic pelvic pain, which sometimes may be confused with chronic prostatitis type 3, which means without any kind of bacteria, which has been observed before at the normal, I would say traditional cultural level. Sexual dysfunction, sometimes patients come in because of erectile dysfunction, or even more important, acquired premature ejaculation. And even more important to me, many times they are completely asymptomatic, which means no symptoms at all. And therefore, you should be as much comprehensive as you can in approaching your patients with a very comprehensive analysis, thus including semen analysis per se. How to define, how to diagnose MAGI after exclusion of any kind of UTI, urinary tract infection, thus including urethritis. You should be able to perform semen culture, or even more important now, PCR analysis, multiplex PCR, are the, I would say, more accurate modality at this time to investigate this kind of patients. Don't confuse leucocytospermia, which means a high value of white blood cells, into the semen context, and bacteriospermia, which means a real infection. Interestingly, if you try to combine the two things, male infertility on one side and MAGI on the other side, this is a sort of sum up situation where you may find at least 4 different mechanisms through which our infections are able to promote damaging of, or I would say, an overall damage of our spermatogenetic process. Production of ROS, very easy to be understood. At the same time, inflammatory cytokines. And if you get a look to what has been published up to now concerning SARS-CoV-2 infection, you may remember that certainly enough, there is at least one, I would say, 1,000 papers dealing with the concept of cytokine storms, which is the case even here. Impaired secretory capacity of the accessory glands. This is a second modality, anatomical obstruction, subobstruction from the organic standpoint. And finally, a direct negative impact of the microorganisms toward our sperm cells. So at least 4 different modalities to correlate the infection and the bad outcomes in terms of male fertility. If you get a look, for instance, to the most popular one, which is ROS in semen, how many papers have you seen concerning this topic? I probably remember more than 1,000 or probably more than 10,000 papers in this field. What is clear is that the higher the value of inflammatory situation and inflammation, the higher the probability of having a sort of impairment of sperm functioning, at least at the level of motility, viability, capacitation, and acrosome reaction. But data are telling us, and Professor Sheena told you before, that there is actually even an even more important correlation probably with the DNA quality, an increased amount of DNA fragmentations as well. Going further, what kind of microorganisms are potentially related or responsible for MAGI? Enterobacteriaceae from the bowel for sure, but at the same time, don't forget to analyze whether your patients are coming in suffering from symptomatic or asymptomatic infections from Chlamydia trachomatis, Uroplasma urealyticum, Mycoplasma, and Trichomonas vaginalis. Candida albicans, it is not that frequently observed. For my cases, for instance, we've seen probably no more than 1 cases over the last 5 years, which is not that much. It is certainly not that frequently observed. But at the same time, whenever it is present, you should understand whether or not that gentleman deserves to be treated. This is a study which has been recently published in scientific reports. They were able in vitro to analyze whether some, I would say, strains of gram-negative uropathogenic species, mostly Escherichia coli strains, are able to, negatively impact toward sperm productions and sperm quality. And what they found was that, indeed, there was a huge correlation between at least one of the strains, which is Escherichia coli ATCC 25.9.22 mostly, which is able to promote a sort of increasing numbers of damages, which means it is able to increase the production of ROS. It is able to, in vitro, of course, promote an increased amount of sperm DNA fragmentation to reduce sperm progressive motility. At the end of the day, it is able to promote a damage. Escherichia coli is probably the most prevalent germ coming from the bowel to the genitourinary system in both men and women. But what is relevant is that some strains are really able to produce damages, which means at the end of the day, once again, to produce impairment of fertility outcomes and impairment of fertility capacity. This is an in vitro situation, but it is the case even in vivo. This is the paper that Sheena was referring to before. We evaluated roughly 1,700 patients coming in because of primary infertility, and all those patients, have been evaluated, I would say, off from the EAU guidelines, since, as you probably remember, most of the guidelines from the scientific societies do recommend to analyze semen culture whenever patients are coming in with symptoms on one side, or on the other side of the coin, because of leucocytospermia, which means no less than 1 million white blood cell per ml. This is relevant since we are skeptical concerning the importance of having inflammation at the same time of infections. Is that true? We don't know. What we found was that up to 21% of our patients were positive for infections at the semen level, although they were completely asymptomatic. And therefore, according to most of the guidelines, we shouldn't analyze those patients. This is relevant since positivity for infections was also associated with a reduction in terms of sperm concentration. And that was significant from the statistical standpoint and at the same time from the clinical standpoint. Get a look at the first red square. If you try to understand what kind of analysis we perform a multiplex PCR analysis, which is something more accurate, sensitive, and specific for evaluating any kind of biologic liquid tissues, from my perspective, as compared with the traditional culture. Interestingly, 8% of our patients were coming in because of asymptomatic infections, and 8% of those were suffering from an infection by Uroplasma urolithicum, which is an intracellular germ, which was not able to find any kind of traditional semen culture. And therefore, whenever a patient is coming to your office because of infertility, both unexplained, idiopathic, or I would say quite clear in terms of causes, don't forget to evaluate whether there is the reason for you to perform a multiplex PCR just to assess whether a further cause of infertility is there. And that was the case for us. At the same time, there was an important issue, which is multiple infections. Indeed, roughly 2% of our cases did report or have been found to have multiple infections at the same time. Is that important from the clinical standpoint? Data will tell you something more later on. But what we found was that there was an improvement after those infections have been treated. And this is the case for us to keep going on evaluating our patients from the multiplex PCR standpoint. This is the paper which has been published 2020 concerning the importance of having Uroplasma urolithicum infection at the semen level. What they found was not only to assess Uroplasma urolithicum in a quite large group of patients from China, but they also did correlate the importance of having Leucocytospermia and Uroplasma urolithicum infection at the very same time. And what they found was that the combination of positive Leucocytospermia and Uroplasma urolithicum at the semen level was an important issue for patients having a lower sperm concentration, a lower total sperm motility, a lower value of normal morphology. One more issue, they also demonstrate that after having been cured using doxycycline or tetracycline, those gentlemen did improve each one of those parameters. According to the importance of having good quality data, at least in terms of numbers, this data is telling you that numbers are important, and the cohort of patients who have been evaluated in China was quite high. Well, they found that Uroplasma urolithicum was important. Most of the times it could be associated with Leucocytospermia, and the combination of the two was absolutely worse in comparison with one of the two as separated issues. After being cured, this gentleman did report an improvement of many of the parameters. One more issue, Mycoplasma and Uroplasma, they may be associated quite frequently with Chlamydia trachomatis. And therefore, what we learned from the cases, both at my institute and the cases which have been published in the literature over the last 5 to 10 years roughly, it is that evaluating the presence of intracellular microorganisms is really, really relevant. Going further, if you get a look to the relevance of Chlamydia trachomatis, we did not find that many cases in my series, honestly speaking. But at the same time, you may use a more easy to be used and found, method of evaluation, which is the presence of IgA antibodies in the semen. And what I found was that the presence of IgI was relevant to understand in comparison with controls who were still with the chlamydia, that infertility was certainly much more frequently observed in the case of positivity versus negativity. There is one more issue, which is concerning the relevance of leucocytospermia as a potential proxy of being infected. This is really relevant. Indeed, most of the guidelines do suggest to perform an evaluation of the level of inflammation, which could be a good proxy of infection. I'm completely skeptical about that issue, and data seems to support my skepticism. This paper has been published according to the importance of infection plus leucocytospermia and the potential impact toward sperm DNA fragmentation index. What they found was that there was a number of different germs at the semen level. This is the bacterial prevalence. They, at the same time, evaluated DNA fragmentation using a kit, which has been called Sperm DNA Fragmentation Assay Kit, SDFA, which is certainly not that sensitive and specific as the COMET one. They evaluated the correlation at the sperm and correlation analysis between leucocytospermia and sperm DNA fragmentation index. And what they found was that the higher the leucocytospermia level, the higher the level of sperm DNA fragmentations. Sperm DNA fragmentation was certainly higher whenever multibacterial infections were present. And therefore, a single strain infection in vitro demonstrated to be associated with. This is the case even in vivo in subfertile men, but the higher the number of germs at the very same time, the higher the probability of having an higher value of DNA fragmentation. We performed an analysis in roughly 500 patients coming in a time frame of roughly 8 years. They all have been evaluated comprehensively with both infections evaluation, which means multiplex PCR, and leucocytospermia parameters. What we found was that according to the EU guidelines, we are challenging my own guidelines. I'm quite happy to do that and to explain what we found. Challenging the guidelines, we decided not to perform semen analysis in terms of multiplex PCR, only according to the number of white blood cells at the level of semen. In that case, we have missed roughly 80% of the cases of positive semen analysis, which means we have missed a relevant number of infections. And since infections have been demonstrated to be associated with poor quality of sperm parameters, missing those infections could have promoted a very bad outcomes in terms of spontaneous pregnancy rates and, even more important, ART cycles. And therefore, although leucocytospermia may have a detrimental effect on semen quality, We cannot rely only on leukocytospermia to assess whether a patient has an infection or not. And that's the reason why, at least internally speaking, we decided to perform a multiplex PCR in every single patient coming to the office because of infertility. What about pre versus post? What this paper, which is not that strong, but at the same time in terms of number, but it's certainly important in terms of backbone and baseline idea. Well, whenever you're going to treat a patient using antibiotic treatment because of an infection, pre versus post semen analysis was able to demonstrate an impressive improvement of all parameters. Well, as a scientist, as a researcher in the field of reproductive medicine, I must admit my skepticism concerning this kind of impressively good results after antibiotic treatments. Forgive me for this kind of definition of my skepticism, but all p-value below 0.001, my God, they are so impressive to me. What is clear is that whenever you have not done any kind of specific investigation concerning the presence of Mycoplasma hominis at the level of your patient's semen, you would have been missing the infection itself. And therefore, you couldn't suggest your patients to be treated with any kind of antibiotic. Therefore, at the end of the day, what our guidelines are telling us is that treating male accessory gland infections may improve sperm quality, although it does not necessarily improve the probability of increasing conception. This is an important sentence, since the take-home message is you should be absolutely sure that every single risk factor which might be responsible for having one of the cases of idiopathic, unexplained, or even inexplicable infertility, you should be able to check whether an infection is there. From my perspective, unfortunately, 20% of the patients are completely asymptomatic, and leukocytospermia per se, the investigation of leukocytospermia per se, is not enough to define the presence of an infection. And therefore, in the everyday clinical practice, we are challenging our EAU guidelines, deciding to perform such kind of investigation in every single man coming to the office. I think we are very close to the end, and therefore I do not have time enough, I'm so sorry for that, to discuss about the issue of virus. I want just to remind this topic, since after bacteria and the so-called Candida albicans presence, which is not that frequently observed, viruses should be considered as well. I'm not dealing with SARS-CoV-2, but certainly I'm dealing with HPV. This is my final slide for you guys tonight. HPV DNA has been found in semen in 20% of the cases in this quite large study, which was a systematic review and meta-analysis of many other studies. What they found was that as compared with general population, which does not mean at the end of the day fertile persons alone, but the general population, those coming to the office because of infertility purposes, they did present a double prevalence of infections because of HPV. The most relevant issue is that HPV 16 was the most common type of HPV present in this kind of category. And even more important, I jumped to my study. We observed that high-risk HPV infections, thus including HPV 16 and 18, they were associated with a higher value of DNA fragmentations. And therefore, even viruses should be carefully investigated in this specific setting. Thank you very much for your attention. I'm so sorry for being that late and quite long in, dealing with my lecture tonight, but thank you very much for attending.
Okay, that is fantastic. That was such a lot of information. And to be honest, I just cannot understand, given the information that we've just heard about and the incidence of 1 in 5 men having these infections, why we aren't doing more in the clinic. Can you explain from your point of view, I mean, is there a disconnect? Why do we not understand that this is an absolutely vital part of a man's workup?
If I may, there was a text message in the chat telling, wow, wonderful, finally someone has been investigating men, which is the case. If I may say something more, which is not only related to the infection profile of those gentlemen, we observed over the last 10 years that still 50% of the cases coming to the office just for being evaluated by the andrologist and the person who is an expert in the field of male reproductive medicine have been already treated at an IVF center, and couples have been treated with IVF without the patient, the male part of the coin has been ever investigated. This is terrible. And this is part of the answer to your question. I do believe that there is a sort of dichotomy between real life and research. But at the same time, whenever you do have a patient coming to the office because of infertility, with idiopathic infertility, why don't you study the patient as much comprehensively as you can? I do believe that we should try and answer all those cases of idiopathic infertility. And most of the data which have been published up to now are telling us up to 30% of the cases are idiopathic, which means that no cause, no treatment at all. And why don't you study at least the infectious profile? We do have 2 out of 10 patients suffering from an asymptomatic infection. Most important to me, asymptomatic infections are mostly due to intracellular germs. And whenever you're not going to perform what science and research has produced, such as PCR, well, you're still missing many data. And therefore, you're not able to help your patients in a proper way. That's my personal profile. I'm quite aggressive, but I'm very, this is reality in the real life setting.
No, I'm delighted you're passionate about it because I love passionate people. But the other thing, the other take-home message from me, which is really quite shocking, and I didn't know at all, was the fact that you do not see leucocytospermia with these infections. And if we're just doing a semen analysis and we're looking down the microscope and we don't see more than 1 million leukocytes, where we go, well, that guy doesn't have an infection and that's fine. And actually we're missing out this enormously valuable piece of information.
Absolutely.
So that's a take home to me. I've got lots of questions here, so let me ask you some of them. When would you recommend to repeat a semen analysis after you put someone on an antibiotic?
This is an important issue. First, when to suggest to repeat a semen analysis on a, I would say, daily basis, which means even in men who have not been discovered having any infection. This is a very question mark, since according to every kind of guidelines, you should perform just 1 semen analysis whenever it is normal. But data are growing, telling us that probably that is not the case for that gentleman to be completely normal. Whenever you are going to repeat in the very same setting, a second semen analysis, something will be observed. At the same time, what you, Sheena, and I do believe is that probably macro value, which means morphology, motility, numbers are not enough. We should perform something more, thus including DNA fragmentation indexes. After the treatment with any kind of antibiotic, if we do believe that a spermatogenetic cycle should be the method to evaluate time frame, it should be 3 months time.
Yeah.
At the same time, there are data telling us that 75 days could be enough. Some data come after 1 month. I do personally believe that it would be better for you to double check after 3 months time.
Yeah, but I think there's a problem here as well, because once the person has had a semen analysis, if they were given the information that they needed to go on an antibiotic and they had to wait for 3 months when they finished the 7-day cycle of an antibiotic, there are a number of the treatments that wouldn't wait. And so the patients are, they're on a conveyor belt and they can't postpone optimizing their sperm before they have the treatment. And I think that's another real issue for us.
It is, absolutely.
I find it difficult to treat ureaplasma even after antibiotic courses. It's still present. Can you suggest another treatment for it?
How many types of antibiotic treatments did he or she use? Since you know what, we according to the guidelines, not only the sexual and reproductive male panel guidelines, but even the infectious diseases and the microbiologist guidelines, you should start using doxycycline 100 milligrams twice a day for 10 days, at least, even up to 15 days, or you may use azithromycin 1 gram once to be repeated after 12 to 15 days whenever it is needed.
Mm-hmm. Now we've got another question, and I've heard this question before when I've said that people should be checked out for infections, and they say it's unusual for our samples to grow anything, even when we send them off to the lab. What's your answer to that? Since
it is a traditional form,
probably.
And that's the reason why you should perform multiplex PCR.
Yeah. Okay.
It has been the case for many studies, indeed. I do believe that most of the guidelines, as a whole, I would say, not only the European Association of Urology guidelines, but most of the guidelines do rely on semen cultures. And I would say we are in 2021, we do have an impressive amount of different techniques which could be used whenever they are available, thus including multiplex PCR. And that's the reason why most of the intracellular, germs cannot be observed whenever you are not going to perform a multiplex PCR or something like that.
Yeah, okay. There's a message rather than a question from Jonathan Ramsey, and he says, thank you, absolutely agree. I worry that we will inadvertently encourage non-urologists to treat too many patients, thus adversely affecting the microbiome. What do you think?
Wow, that's a compelling question, a compelling observation. I completely agree. The microbiome is very important. Honestly speaking, however, we should say that up to now, we did consider, for instance, the testis as a sort of immune privileged site and completely sterile, which is not the case. Well, what has been observed at the 16S evaluation modality is that the testis is not sterile, and therefore something is already there, both in fertile and infertile men. What has been observed is that probably infertile men, they do have a different kind of microbiome with a larger diversity in terms of germs versus a lower homogeneity in germs in itself. What could be the case for men who have been treated is that this kind of homogeneity in terms of microbiome could be, I would say, disgregated. This is the case, probably. We do not have data enough to say what's going on at the level of the microbiome, but it is the same for the microbiome, for the viral biome. And so, I don't know, I would prefer having my semen as much sterile as I can, according to those germs which have been defined as pathologic germs, of course. So we cannot stay, from my perspective, with a uroplasma urolithicum at the semen level, with a sort of ping-pong situation between the male partner and the female partner as well, since data seems to suggest that, for instance, recurrent pregnancy loss are much more frequent in those couples where this kind of ping pong situation is present. And therefore, I think that eradicating the infection per se should be compulsory.
Well, that's very interesting. There's another question here saying, are there any comprehensive guidelines on testing semen for microorganisms, including the management? As in the UK, the PHE no longer even has it in its documents. So we need new guidelines then.
Yeah, I know. No, unfortunately, I do completely agree with the observation. Honestly, once again, is there any comprehensive guidelines suggesting to perform 2 versus 3 versus 4 semen analysis in a man coming to the office because of non-obstructive azoospermia? No. At the same time, data which have been produced over the last 2 decades roughly are suggesting that probably you may be sure, completely sure, to have an azoospermic one after 10 semen analysis.
Yep.
So I think it is roughly similar. We are going to operate on a patient because of performing a micro-TZ after 2 semen analysis. Is that enough? I don't think so. And that's the beauty of the research setting. We should understand how to proceed with in the real life setting, using data from the real life setting as well.
Yeah. Okay, and I think probably one final question here, and it's, are there specific sperm factor differences between viral and bacterial infections? That's a tricky one.
Wow, why tricky one? Honestly, if you, once again, unfortunately, most of the data coming from, concerning HPV infection, for instance, they do come from the very same group. So, if you do consider reliably enough those data, the sperm parameter could be a reduction in sperm motility, since they demonstrated that HPV is able to enter the sperm cell and to reduce motility. Is that enough as a parameter of viral infection? I don't think so, honestly speaking, but it is the only parameter in my mind. At the same time, according to my data, HPV infection has been associated with, whenever it is high-risk infection, therefore HPV 16 or 18, they were associated with a higher value of DNA fragmentation. But it is paradigmatic of a viral infection? I don't think so. So I think we are still missing a real parameter which is able to dichotomize bacterial versus viral infection.
Okay, okay. I know there are a number of questions here about DNA tests. If you don't mind, I'll leave them for now, because I think we've probably answered most of those in previous webinars, and tonight's not really about DNA. You don't want to think we're biased. So thank you very much for all your questions. Thank you so much, Professor Salonia, for your wonderful lecture. And I'll hand you back now to Eileen.
So just to finish up and say thank you everyone for joining us. Please do get in touch if you have any more, if you would like to find out more information about our tests, and thank you in particular to our speaker tonight, and who was wonderful in wrapping up, you know, an amazing session for the last session in our series. But in particular, thank you to everyone who's joined and for all of our speakers in our 2021 series. So we very much hope we will announce our 2022 series very soon, and we'll see a lot of these familiar faces back to join us again. So thank you everyone again. Good evening, and don't hesitate to reach out if you have any further questions.
Thank you very much.
Thanks a lot. Bye.
Bye-bye.